need any introduction. I have prepared.
Thank you.
But I have prepared a basic introductory presentation so that everyone can know our speakers and panelists. First of all, Dr. Avinash Pathengay. He's a, I think, eminent retina surgeon from India, and as well as UVA specialist. People practicing UVA are very less in India, who are practicing core UVA, who can diagnose the rare conditions. So he is a director of education and elderly eye care at LVPI. A very, I think, great, receiving a great response globally. He launched Just a Minute Jam Clinical Pulse in Ophthalmology and Optometry. He's associated with LVPI since past 20 years, and he has played an integral role in establishing retina services there at Visakhapatnam campus. He graduated from Stanley Medical College, and he did his ophthalmology residency from Madras Medical College. He did his retina surgery fellowship from Shankar Nethralaya, and also he pursued a one-year international fellowship at Bascom Palmer Eye Institute in Florida under Dr. Harry Flynn.
Thank you so much, sir, for gracing the occasion.
Sir is a co-founder of Retinet India, which has, I think, the speakers and the people who join Retinet are now global. Most of the people attend Retinet meeting in India, and he has many presentations in both international as well as national platforms with many book chapters, more than 15 book chapters. And he was honored as the outstanding international scholar at the Bascom Palmer Eye Institute. Also, he has received several awards at American Academy of Ophthalmology and Asia Pacific Academy of Ophthalmology, and also World Ophthalmology Congress. And apart from being a great retina surgeon, he has love towards nature also. He has inaugurated many beautiful award-winning gardens at Visakhapatnam, at LVPI's tertiary campus, also at Vijayawada. So thanks, sir, for joining us.
Thank you so much, Vineet.
Now, Dr. Jorge Rocha, he's from Brazil, and he has done fellowship from Doheny Eye Institute, California, and also he completed his PhD from Sao Paulo, Brazil. Sorry if the pronunciations are wrong. He's also the president of Eye Retina Eye Institute and a general secretary of Brazilian Council of Ophthalmology. He has, I think, found Brazilian Retina and Vitreous Society, and he is also secretary of Brazilian Retina and Vitreous Society. And he is a member of eLife chair of Retina World Congress, also executive board member of Retinal World Congress. And he is also an executive board member of Middle East Ophthalmology Meetings Academy. And he has to his account many articles in peer-reviewed journals and books. So thank you, Dr. Jorge Rocha, for joining us.
It's great to have you, sir.
Now, Dr. Tatiana Avanesova. I got her most of the introductory part in the last minute because somehow the Russian website is not open so easily. So I could not get her introduction from LinkedIn. So I took from her. Thank you, Dr. Tatiana, for sharing it at the last minute. Thank you so much. So she's a vitreoretina consultant in the ophthalmic department of Presidential Administration Hospital, Moscow. He's the founder of Retina Research and Treatment Foundation. She has specific interest in retina detachment, in which she has also done her PhD on. And currently she is researching about screening diabetic retinopathy in Russia. She has more than 30 papers in peer-reviewed scientific Russian library. And also she was awarded as the best retina coach in Thessaloniki Vitreoretinal School in 2021. Thank you, Dr. Tatiana, for joining us.
Thank you for invitation. Thank you.
Now, Dr. Satyen Deka, he is luckily a part of ASG, and he has been one of our teachers, as well as he's one of the very good retina surgeons in ASG, which we are really proud of. So he has done his MS in ophthalmology from Assam Medical College in DNB. He has done his fellowship from in general ophthalmology from Shankar Deva Nethralaya, Guwahati, and he has done his retina fellowship from Shankar Nethralaya, Chennai. He has been trained in vitreoretinal disease and cataract at Moorfields Eye Institute, London. Also, he has done his training from Johns Hopkins University in USA, Wilmer Eye Hospital also, and Wills Eye Hospital, Philadelphia, in ocular oncology. He's a senior consultant, as I said, in ASGI Hospital. He's also a senior surgeon as well as head of our Guwahati center. He has more than 16 years experience in Shankar Deva Nethralaya, which is very, I think, eminent hospital in India with all specialties of ophthalmology. He is also founder and consultant of Lions Eye Hospital in Assam, and he had been a head of department in local hospital in West Bengal. Thank you, Deka sir, for joining us. So I am done with my presentation. Thank you all for joining.
So can we get started?
Yes, definitely, sir.
Yes, sir.
Okay. Anamika, can you share the presentation?
Yeah.
So
All right.
let me also introduce my colleague here, Dr. Anamika Patel. She finished her fellowship and then she's a faculty with us for the last 2 years. And she's heading out to the west to Moorfields to pursue her uveitis training for 2 more years. So and she has been of a great help, great clinician, great observational skills, and she has helped in putting this presentation together.
Thanks, Dr. Avinash, for the kind introduction. So today the topic is acute retinal necrosis, and let's get started. So I have 13 questions for you, Dr. Avinash, and I'm gonna grill you with each question. So the first question has one part. So the first question to you is that what are the challenges in making a diagnosis of a acute retinal necrosis when you see that in a clinic? What comes to your mind?
Now, when I talk about the challenges, much before that, let's understand the diagnosis of acute retinal necrosis, right? So we have grown up with an understanding that it's a peripheral retinitis. Not only peripheral retinitis, it's a progressive retinitis. And when we mean about progression, it progresses circumferentially, right? So it's a peripheral retinitis, necrotizing retinitis, which spreads circumferentially. And it is also associated with vasculitis and vitritis. So those are the 3 hallmarks which have been classically described, and that's what we have grown up with. And the challenges, I would say, to which we can come out is the atypical features or the early features, right? So the early features are sometimes it can have multiple focal retinitis in the periphery, which are very tiny ones. If picked at this stage, then the chances of halting the disease and improving the prognosis is phenomenal. And the second is because these patients can also present with scleritis as a red eye to the clinic, or they may present with initially with anterior uveitis. And if not being diagnosed early, then the chance of progression becomes obvious. And when it starts progressing, then the chance of prognosis also becomes questionable in terms of good prognosis. So those are the challenges. Early presentations, if we can pick up, or an atypical presentations in the form of scleritis or an anterior uveitis, if we don't identify, then we may miss the boat.
Thanks, Dr. Avinash, for bringing a very specific point. So this is just a very good illustration where we can see a very classic presentation of a retinitis, the circumferential spread that you say. And it's really obvious based on the pattern recognition to pick up the diagnosis where you have a central clearing and you see a peripheral retinitis. And as you had mentioned, the patients can present with either a pigmented KPs or a mutton fat KPs. So I think this is the point that you were trying to bring in the earlier presentation of the acute retinal necrosis, right? Would you like to share some more light here?
Yeah, absolutely. So now if you look at this particular patient, when the patient presents, and you just look at the nasal quadrant, right? I just want you to focus on the nasal quadrant. You have pinpoint areas of retinitis. Now, sometimes this is all what you would get to see. And when you have a peripheral pinpoint retinitis, having a differential of acute retinal necrosis should be high in the main. So don't wait for the typical coalescence and then the circumferential spread to happen. By then, we have lost significant amount of time. So anytime when you have a peripheral pinpoint area of retinitis, multifocal retinitis, have the differentials of acute retinal necrosis very high in your mind. And you can see how the patient had progressed. On the left-hand side, when the patient had presented with multifocal retinitis, but on the right-hand side, you see the eventual progression which has happened. So it is at this stage where the disease can get into a more complex state.
Yeah. So if I could just share the resolution, what really happened in this case. So it's pretty much clear that the earliest point was the presence of these teeny tiny lesions, and eventually they all coalesce, like you just mentioned. And here we can, is just for the understanding of our viewers, that it indeed becomes a full circumferential retinitis, and then you can see the resolution which is happening over a course of time. So you brought in a very important point about this multifocality and how astute a clinician needs to be to really pick up at this juncture, because this is the time when the mind really plays with you, and it's a possibility that one can mess up. So if I could just conclude the points that you had that you have already mentioned for acute retinal necrosis, that first it's a pattern recognition. You have a classic retinitis, which is circumferential spread. It has a rapid progression, so we need to act fast. And what we might see in terms of retinal vessel involvement is the arterial involvement. And we have already discussed about the anterior chamber involvement in terms of either a pigmented KP or a mutton fat KP. So with that in mind, the question for you is that, do you think it's possible for ARN to recur?
ARN can recur, but it is extremely rare. So if you look at ARN to recur, if we go back and what is that evidence which exists, most of these patients would have developed acute retinal necrosis when they were young. So in the first or second decade of life. And the earliest recurrence what we have seen in the literature, somewhere around 3.5 to 4 years when they start recurring. And some may even recur after 20 years. So, and the next important point is when it starts recurring is it may happen in the other eye. It may not happen in the same eye. So always look into the possibility, because here again, when we have to question that when we start treatment in acute retinal necrosis, we have been taught that the treatment has to extend for about 2 to 3 months, right? And one of the goals of the treatment is for the prevention of an acute retinal necrosis happening in the other eye. But in case of recurrence, one has to understand it is not the same eye. It can happen in the other eye, and it can happen many years after the initial resolution of infection on the same eye. So younger the individuals, the chances of recurrence future in their life is pretty steep. And that's something which we have to remember in cases of acute retinal necrosis.
Yeah, very, very important point. And I think through this presentation only, I learned this point, that a pediatric age group, the other eye involvement, and the time period, the minimal being 3.5 years to up till 20 decades as well, 2 decades as well. So that's the time frame which is there in the literature. So I think it brings a very important thing in the clinic, that when we are speaking to our patient during the time of counseling, it's important to inform our patients as well about the same thing, especially with the younger kids, to the parents. So would you like to share some light on a mimicker for the ARN, like, in a periphery, could something, mimic acute retinal necrosis?
Now, if you look at a retinal necrosis, the etiological agents can be many. That's the reason why I would like to call acute retinal necrosis as a morphological diagnosis.
Yeah.
Right? So this phenotype can represent various organisms. The commonest are the herpetic virus, right? But can also be seen in toxoplasmosis. but can also be seen even in lymphomas, can be confused with acute retinal necrosis. And this particular slide is very rare. This is the only time I have seen, the first time I got to see where tuberculosis can present with acute retinal necrosis. So it has a very classical peripheral spread. It has not involved posteriorly, but it has gone peripherally as well. So we have about just about 2 cases. I'm not trying to highlight tuberculosis as a possible etiology here, but the point which I want to make, it's a morphological diagnosis, and there can be various etiological agents which can have a similar phenotypical manifestations, which we have to keep in mind.
Yeah, duly noted. And I think the point on lymphoma was extremely important, and we need to keep that in mind, especially for our patients where it could act as a mimicker. So now when we have understood the typical and the atypical presentation about the recurrences and where other disease could as other etiology where it could masquerade as, let's move on to the second question of today evening, and that is, what is the role of clinico-etiological classification for our patients?
So
keeping that in mind that it's a morphological diagnosis, the point
correct.
I've already made.
So just reiterating fact, it's a morphological diagnosis. And probably here I would also take a time to make people understand why it is why it is called necrotizing retinitis, right? So I would like to draw parallels here, though we are retina specialists, even in corneal diseases, when there is necrotizing stromal disease and you have non-necrotizing stromal disease, right? So something similar happens in retina also. You have necrotizing retinitis and non-necrotizing retinitis. The commonest cause of necrotizing retinitis, unifocal, we know it's toxoplasmosis. But when it comes to virus, right, virus can present with both necrotizing and non-necrotizing variant. How does one clinically differentiate a necrotizing and a non-necrotizing one? When it is opaque, the one like what you get to see here, right? This is classical, the necrotizing retinitis. The other one you get in cytomegalovirus retinitis, the fulminant variety, which is another common manifestation of a necrotizing retinitis. The non-necrotizing would be granular and would be translucent. It will not be opaque like this. So that's how we can differentiate between a necrotizing and a non-necrotizing retinitis.
Thanks, Dr. Avinash. The point on the transparency and where it would appear as a granular and that we need not call as a necrotizing retinitis was a pretty good one. So based on the age.
Yeah, based on the age, let's understand that younger the age, the HSV2 is more common, and in the middle age, HSV1 is common. As the age increases, VZV is something which is common in our clinical settings. So, but it does not have to be all the time that if they are younger, it has to be HSV2, and it has to be in an older individual comes, it has to be VZV. It can be anywhere around. But it is also important that as and when we can understand the etiologies of the various viruses which commonly manifest as acute retinal necrosis, there's systemic associations with them. The younger the individuals, the chance of maternal herpetic infections can be there, where the neonates can be infected, right? Or in the middle age, the patient can have history of encephalitis or even an keratitis, following which the patient can develop acute retinal necrosis. And we all are aware that a patient's presenting or having history of chickenpox or even shingles can present with acute retinal necrosis. And most of the times they don't coexist. What is most important is once the systemic infections starts resolving, right? Or antedates, you have a history of a systemic infection. It is then when, if a patient complains of a decrease in vision or redness, the possibility of acute retinal necrosis should be high in the differentials.
Yeah. Having understood the second point, which was very clearly illustrated that, younger, middle, and older people, let's move on to the third question that we always associate retinitis of viral etiology with the central clearing. So what is the real reason for that? Why does that happen? Is it really clearing or it is something else?
So now, whenever a pattern we just discussed about when it presents with the necrotizing retinitis. So even when it starts clearing, right, or when it starts resolving, it has a pattern. And this pattern helps us to identify the response and also to a certain extent the etiology of retinitis. Now, when you have an extensive retinitis about, say, involving two quadrants, apart from the margins, which everybody looks out for, the resolution also starts from the center, right? Now, it's here where I would like to slow down and make people understand that in viral retinitis, right, most of the viral retinitis, when they start resolving, they don't resolve with hyperpigmentation, right? Toxoplasmosis can resolve with hyperpigmentation. Tuberculosis invariably resolves with hyperpigmentation, but virus rarely resolves with hyperpigmentation, barring HSV2. So this is the only exception which one has to keep in mind. I think we have a case which will show how we can make a etiological diagnosis based on the clinical presentations as well. So in any case of a large necrotizing retinitis, just do not keep looking at the margins. The margins are important, the rounding, what we just say, or what we usually consider in the time of resolution, but focus even in the center. And when you start seeing something clearing in the center, it's actually a good sign for us to say that the clearing has already begun in the center as well. So don't panic that if something different is happening there. It is something good, and it helps us to say that the non-pigmentary resolution pattern helps us to make a diagnosis.
Yeah, I really like your analogy where you drew that parallel with the keratitis, that you look at the borders, and here also you were kind of alluding to the same. Nevertheless, what again is extremely important is to understand that other than the border, what one needs to look at is in the center of the retinitis as well, which is actually the representation of the atrophic retina because of the cell death that happens. So you had spoken about scleritis just a few minutes back. So what is the deal with the scleritis in our patients?
Now, we know that when an acute retinal necrosis happens, and the herpetic virus and neurotrophic virus, right? So it probably takes its course to the long ciliary nerves, and then there is an inflammation which sets in the adjacent choroid and can also involve the sclera as well, right? The adjacent structures which are there. And it is then when a retinitis, which otherwise would have just presented with loss of vision, the patient would start complaining of pain. But this is something which we have to remember. So usually retinitis per se will not cause pain. But if it's associated with inflammation of the sclera, the pain can be such overwhelming. And sometimes, because of the anterior scleritis with which these patients can present with, the retinitis can be so peripheral that the treating ophthalmologist would not look at the retina in the periphery and might completely miss an acute retinal necrosis. Here is one such patient who presented with scleritis, and when we had to peep into the fundus in the periphery, so we saw a patient with peripheral retinitis. So this is something which we practice routinely, even when patient comes with scleritis, dilate the retina and look at, dilate the pupil and look at the retina and the periphery so that you don't miss an early acute retinal necrosis. And the pearl what is there, if retinitis with pain, think of acute retinal necrosis and don't miss it.
Yeah. So you spoke about the scleritis presentation where you ensure that the pupil is dilated and that we do not miss on the retinitis. Of course, PET scan plays a very important role in telling us if at all there is actinous fluid as well there. So what's your take on the infectious variant?
Okay, now when we start consuming the knowledge which is given in the text, because most of the text borrows the literature which is from the rest, we do understand the most common cause of infectious scleritis happens to be virus. But when we practice in India, we rarely get to see infectious viral scleritis sitting in front of us in day-to-day practice. Now, most of the times we see a bacterial scleritis. And why am I talking about this point? Because we borrow the knowledge from the textbooks, right? Initially when you start consuming the knowledge, then we try to equate, oh, am I looking at infectious viral scleritis, which is what is mentioned. But there are ways by which one can differentiate the infectious, viral, and the bacterial ones. So the viral scleritis are usually diffuse. It does not have a nodular component. If you see a nodular component, do not jump into to make a diagnosis of viral scleritis. Second, if there is a pus point, right? The pus point is very characteristic of a bacterial scleritis or even a fungal scleritis, but not of a viral scleritis. So, and they are usually, the viral ones are the non-necrotizing varieties. Okay, so these are the key takeaways by which one can differentiate between a bacterial scleritis and viral scleritis. So why I'm talking about this is one has to be cognizant of the place where we practice, and then borrow the literature and the evidence what is available, and then apply in the country or the city where they practice, and then make an appropriate diagnosis.
Yeah, very valid point, because whenever we speak of infection, especially the infectious scleritis, the first thing that would come in anybody's mind would be, let me look for the pus point, because you need to look at that one yellowish, lesion. And the beauty with the viral antidischleritis is that it has got no pus point. So for me, Matt, to my understanding is that viral scleritis is really a diagnosis of exclusion. What's your point on that?
I agree with that because I'm not very comfortable in making an isolated diagnosis of viral scleritis when I get to see them in the practice, to be honest.
Yeah. All right. So I think we have understood that, how the infectious variant can present and how a non-infectious variant can present. So let's move on to the other kind of anterior segment manifestation that could be considered as a helpful things when you are making a diagnosis for the arm.
No, I like this discussion, which has gone beyond retinitis, right? So we went on to discuss about conjunctivitis. We went on to discuss about scleritis, right? And then we are looking at other anterior segment manifestations, which can help us to make a diagnosis of acute retinal necrosis, right? So key point in viral retinitis, in anterior segment, we have again evolved ourselves with an understanding that keratic precipitates become pigmented during the course of the treatment, right? Initially, when they're present, they're not pigmented. But in a setting, in an acute setting, if one gets to observe a pigmented keratic precipitates, right? Think of a viral etiology, right? Think of a viral etiology. So the second, I would say, think of any infectious etiology. Next, I would think about is toxoplasmosis and tuberculosis, but virus is top in the differentials when you see a pigmented keratic precipitates in an acute setting. So that's where the importance of pigmented keratic precipitates lie to help us to consider a diagnosis. Just like how do we extrapolate this in a day-to-day clinical practice? The moment you get to examine a patient in a slit lamp and you have fresh pigmented keratic precipitates, dilate the fundus, right? And no shortcuts there. Examine the peripheral retina so you're not missing out on peripheral retinitis. So that's something which one have to, include it in your evaluations, comprehensive evaluations.
Yeah, very pertinent point, because often people get confused by looking at a pigmented KPs. But one thing which again can be helpful is by looking at the intraocular pressure as well. Like for example, in order to come to a certain etiology that I'm dealing with a viral etiology, I think the rise in the rise in the intraocular pressure and the presence of these pigmented KPs are something which kind of take us or funnel down our thoughts that we are probably dealing with a viral etiology. The other two things, which I would like to add. Yeah,
that's a point which needs to be considered as well, because the trabeculitis which can happen can also be associated, is one of these reasons for the raised intraocular pressure. Now you see how acute retinal necrosis can be missed, one if does not have a comprehensive evaluation, can be missed as an conjunctivitis, can be missed as scleritis, can be missed as acute anterior uveitis, or sometimes can be missed as isolated trabeculitis with raised intraocular pressure and can just be treated with beta blockers or even carbonic anhydrase inhibitors, right? So these are all possible unless and until we evolve ourselves to do that comprehensive evaluation so that we don't miss out on this diagnosis.
Absolutely. So the presence of the iris atrophy and the presence of like some satellite lesions in the cornea are other two subtle soft markers for the viral etiology as well. Though it may not really fit into the ARN category of patients, but for if one is looking only at the anterior segment involvement, these are two things which I would like to add from my end. So I think Dr. Avinash, we have been speaking for a very long time, and
yeah, and I think
would
we'll
you
just,
like to tell people what is Muddiest point first, because it's a jargon which we use very commonly.
yeah, so I'll just try to recap how we started. We started on how we make a diagnosis of acute retinal necrosis from a peripheral progressive circumferential necrotizing retinitis associated with vasculitis and vitritis. And that's how we have all grown. And then we went on to describe the multifocal pinpoint retinitis in the periphery, which is important. Where if we catch them at that stage, the resolution is quick, the prognosis is very good. And then the other manifestations which the patient can have as scleritis, then the differentiation between viral scleritis, bacterial scleritis. If the patient presents with, pigmented keratic presperates in an acute setting, how does one have to think about a possibility of acute retinal necrosis and the trabeculitis, and the other 2 points you mentioned about the corneal manifestations of previous scar and the iris atrophic patterns. So these are, and also about the pain, retinitis with pain, think about acute retinal necrosis. So that's what we had to sum up what we had just discussed. And now we would have, this is a Slido where you will be able to take your QR scanner and you will be able to scan, and you can type in your muddiest points. Muddiest points are the ones which you're not clear about till what we have discussed till now. So once you are able to type in, then we will be able to understand where the rest of the group is till whatever we have spoken till now. So you can type in the muddiest points. Any fact or concept or any point which you're not having clarity or not clear.
Sir, we are having the chat group also here. So anybody ask from that chat group also? Avinash sir?
Yeah, fair enough.
Dr. Ganesh?
Yeah, absolutely. Sir, you have actually elaborated very nicely on the different aspects and how to diagnose it. I would like to ask, sir, if you have to pinpoint one clinical feature which is absolutely, say, confirmatory of things, what a general ophthalmologist or a person should look for.
It is, Ganesh, it's not on one point where you come, it's a constellation of features by which you arrive at a diagnosis. So, but if you ask pinpoint one, I would say retinitis, peripheral circumferential retinitis is way up in the ladder.
Right, sir. Sir, do you, I'm hoping that you will have regarding management and what are investigations you will go for, but do you do say a vitrectomy or biopsy or PCR for such patients before starting the antiviral therapy?
So Ganesh, I will come to that during the management. I'm just stuck in the clinical presentation so that, we become good clinicians as well.
Yes, absolutely. Sir, one more point which I heard in one of the conference is regarding scleritis. Scleritis, how often do you see a tubercular scleritis vis-a-vis a viral scleritis? You already said that viral is a little rare in our situations compared to somewhere else. but can a bacterial also present without the points which have already been mentioned, without any yellow tinge, nodules as
Yeah,
well?
bacterial and fungus scleritis can present, but many times they are nodular, right? So, and you will have the discharge, which is very characteristic of purulent discharge, which does not happen in viral infections. So that's how one can easily differentiate between bacterial and an viral infection.
Right, sir. Sir, there is question in the chat box which asks how do you confirm that it was related to tuberculosis, the acute retinal necrosis like picture in the periphery? How did you confirm that?
Okay, so we have Anamika, can you go back to the slide? So you make a diagnosis based on the clinical presentations also. So I'm of a strong belief that the diagnosis of tuberculosis can be made clinically than just on MAN2 test, right? Today, we suffer with most of the anti-tuberculosis treatment being indiscriminately being given just because on MAN2. So I don't like to treat the MAN2 alone, okay? So I will start with this point. And then the clinical point, which I want to emphasize is, yes. So here you are seeing an hyperpigmentation of the margins, intense amount of hyperpigmentation. So with this, we are ruling out a possible of previous viral infections other than possibility of HSV2, right? So which is quite rare. But number two is this patient. If you look at we are not able to image even farther than this in the periphery. We have published that if there is an active retinitis within a scar or chorioretinitis within the scar, then it usually signifies tuberculosis. Right? So I want you to imagine you have an hyperpigmented scar, right? And then you have an activity of necrotizing chorioretinitis right in the center. Consider tuberculosis.
Okay. Okay.
Yeah.
We have Dr. Tatiana. Yeah,
Thank you.
absolutely. Dr. Tatiana. Yeah, please,
Thank you.
your question.
Thank you so much. Fantastic lecture. I just want to ask you about taking the culture from anterior chamber. Do you do it routinely, or what's your opinion for diagonal?
So I will get to it during the later half of my presentation. The first half of the presentation is primarily on the clinical manifestations.
Okay, sorry. Okay,
Yeah.
we'll wait.
So one more question which is there in the chat box is the amount of anterior chamber inflammation anywhere related to ARN is one of the doctor's question, Dr. Sophie Michel's.
Yeah, it's a good question, but again, I like to reemphasize just based on anterior segment inflammation, we don't come to a diagnosis of acute retinal necrosis. It's a constellation of clinical signs which we have to put together to come to a diagnosis. So anterior segment inflammation, if you're looking at only cells, that would only help us to add topical steroids in the management, right? But or to make a etiological diagnosis, not etiological, uveitic diagnosis of patient is having pan uveitis. Okay, so that's all what it would help. But if there are pigmented keratic precipitates, yes, it will help us to look or even help us to understand that do not miss out on peripheral necrotizing retinitis in these patients. So I've divided the anterior segment inflammation into keratic precipitates and cells. Cells would be for to make a diagnosis and maybe to add topical steroids. But pigmented keratic precipitates, yes, that's a good bargain to take it forward.
Right, sir. Dr. Jorge Rocha, sir, any questions that you'd like to put across Dr. Avinash?
It's a perfect lecture, fantastic lecture. I learned a lot with you. And I agree that scleritis is very few, but I don't know if my experience is different, but in the last 2 years, my 3 patients had scleritis and pain. And when they start to heal, and all the pain gone. And then I think maybe I see more scleritis than usually everybody sees scleritis. I don't know if have any difference between countries and genetics, but that's my experience.
I think if once the treatment starts, the pain resolves very quickly. I agree with you, George. It just takes about a day or two with the anti-inflammatory, the pain resolves very quickly.
Yeah, it's 48 hours, they start to heal and the pain gone.
Yeah, and these are all the very surrogate signs, for us to understand that the clinical diagnosis, especially what is the problem when people are young and they want to make a diagnosis of acute retinal necrosis, there is a small of inherent fear they have I made the right diagnosis, right? So then these are the ways by which it can tell you that we start the patient antiviral treatment in 24, like what George mentioned, in 48 hours, the pain disappearing. It's the first step of confidence which gives to the person who has just made the initial diagnosis, right? You're going, treading on the right path. I appreciate that point, George.
Right. Sir, one fellow has asked you whether these pinpoint lesions that we are talking about in the initial part of the presentation, how can we really look for the central clearance?
Central clearance is not for pinpoint, it's for extensive necrotizing retinitis. Pinpoint will coalesce. Once it is coalesced, then it will start resolving from the periphery and also from the center. And center, we call it central clearing. Because see, what happens is when you start the treatment, then the conventional teaching is look at the periphery, no new satellite lesions. But suddenly something happens in the center, the retinitis starts, it becomes less necrotizing. And people would start wondering, what is this? Are we trying to understand something new from this? Actually, this is a good healing pattern which people have to understand, especially when you're treating viral infections.
So it's basically during the healing phase that you see the central clearance taking
Absolutely.
place.
Yeah. And
so,
again, reiterates the fact, if you go back to the slide, Anamika, if you go back to the slide and then you have the muddiest points, if you have got any.
Yeah, sure. Just give me a minute.
So if you go back to the slide, the point which I was trying to make, the viral infection heals without pigmentation.
We really have
there are quite
lot
a
of
few
points.
questions. Right. So there are quite a few questions already there. So how do you differentiate here, which I'm taking the single line one, HSV1 from HSV2?
HSV from HSV2, one is the age, which we have already spoken about, right? And the second is HSV2 clinically can have hyperpigmentation, right? It will have an hyperpigment. I think we have a slide with it. We'll just show you that also, like how early we picked up, and then the response was very good in that patient. Nodule with scleritis. Why is it bacterial? Good question. So many times when bacterial scleritis happens, right? So there is a history of trauma, or there is a history of infection adjacent, like consider just like a buccal infection which happens, or if the patient is immunocompromised state. So, or if the patient hasn't surgery, like the pterygium surgery which has got infected. So these are the various etiological agents where one has to consider, or a history where one has to consider for a bacterial scleritis to happen.
Right. Sir, I would like to ask one question from myself. Basically, how common do you see ARN post, say, a cataract surgery, immediate post-operative or 2-3 weeks post-operatively? Do you see it often, or is it something not that common?
No,
because
I have not.
they are, yeah.
Ganesh, I have not seen it post-cataract surgery.
Right, sir. So we do see anterior, say, uveitis, which is viral in nature, and once the cornea is cleared, and then it later development of Descemet folds and corneal haze or edema. So corneal Descemet folds and edema, do you consider it as one of the important points to look for in a viral etiology?
I would not lay emphasis on decimal folds, but on the previous stromal scar, something which I would be more important or more interested than on decimal folds.
Sir, any experience in say judging whether the anterior uveitis is of viral nature, other than the Postman Scholzmann syndrome of increased pressures immediately?
Pigmented keratotic prespirates.
Right,
Acute
sir.
setting. Its writing is on the wall.
Right. Dr. Anamika, any more questions?
Well, we still have got a lot of question types of iris atrophy, which could be sectoral and diffuse. Dr. Avinash, you want to take this, the heel arm-like pattern seen in TB, is that secondary to RP atrophy in periphery, where snow banking is having a fibrovascular atrophy?
No, it is not a fibrovascular atrophy. Here, I would not be able to say with certainty because it's extremely rare. So I must evaluate many more cases if it turns up for me to answer this question.
Yeah.
So the short answer is I don't know.
The reason for central clearing and not healing from the periphery.
Okay, it heals from both the sides. It heals from the periphery and also from the center, right? So what happens is when a viral retinitis happens, any of the infection which happens, unless the person is predominantly severely immunocompromised, the host immune mechanisms takes over, right? So it's a complex interplay which happens. So when that interplay happens, the clearing also starts happening. It's not that it is going to stay necrosed for eternity. So that virus has not drank the fountain of youth, right? So, and we also know that these viruses can activate and then go back and hide itself and stay in the dormancy till another situation happens where it jumps up and then reactivates. We know that these things can happen just like toxoplasmosis, and even in cases of virus also something similar. Over a period of time, it can limit itself because of the host immune mechanisms which come into play.
Yeah.
Sir, I wanted to ask you, you have shown pictures over here of retinitis, but the vitritis was not that predominant.
We'll get to that. We'll get to that.
Yeah. Okay, sir. Okay, fine.
I know once we get in the vitreous, all the vitreoretinal surgeons, that's where things starts getting interesting, right?
Right. Okay, I think we can move on to the next part of the lecture, I guess.
All right. So
There
you
you
asked for
go, you see.
vitritis.
Ganesh asked for
Here we are.
vitritis, so vitritis has come.
So what is the grade of vitritis signify and like, do we see real vitritis, or we could be dealing with a grade 1 kind of vitritis as well? Is it possible to have both the extremes?
Yeah, it can have both the extremes. Now, again, let's understand the fundamentals. Retinitis, vasculitis, vitritis is very important for us to make a diagnosis of acute retinal necrosis. But it does not mention the grade of vitritis because there is a variation. Okay, so now this is what we get to see in practice. Is vitritis can be proportional to the amount of retinitis, and it is also known that if the vitritis is very severe, the risk of retinal detachment is very high. Okay, these are the two important points one has to consider, and and also if the vitritis is very high, right? So also should be your treatment to control the vitritis. Now, for a vitreoretinal surgeon, we know that apart from the vitreous, and the vitreoretinal interface is the most important aspect when you're dealing with acute retinal necrosis, because the retinitis has to be dealt with the antiviral treatment. But for a vitreoretinal surgeon, the management of the vitreous and the vitreoretinal interface becomes extremely important. Much before that, a point which I would like to also mention is, since there is a variation in the vitritis, have a tailor-made approach when one considers an anti-inflammatory treatment. So 60 milligram or 70 milligram of corticosteroid is a ready-made approach of treatment in the management of vitritis. You can't have one. So like if a patient presents with grade 1 vitritis, it's also 70 milligram of steroid. If a patient presents with such a dense vitritis and you're not able to see the peripheral retina also, even that patient also gets 70 milligram of steroids. That doesn't make any sense, isn't it? So there is no logical sense in when you're managing. So it's here where apart from a ready-made approach, have a tailored approach and try to use steroids in more than one way so that you can address the inflammation in these patients. There's just few points which I just like to cut across so that the management becomes very effective.
Thanks, Dr. Avinash. We have been displaying all the images which were unilateral, and I think it's time to change that game here. And with that, I'll come to this very specific, we are halfway through now in this presentation. The 7th question: is there a significance of the immune status when we are dealing with the ARN patients?
Right. So the classical presentation of acute retinal necrosis happens in immunocompetent patients, right? So, but it can happen in immunocompromised patients as well. So when it happens in immunocompromised patients, then the presentations can be a little bit different. So what is that little bit difference are we talking about? The difference is bilaterality. And second is sometimes relentless progression in spite of antiviral treatments, right? And the third is it is just not the peripheral spread. You will see it being aggressive and getting into the posterior part of the retina as well. So these 3 important points one has to understand, especially when you're managing within immunocompromised patients: bilaterality and the non-responsive nature it can present with to the antivirals. And third, apart from the peripheral progression, it can progress even centrally.
Yeah.
And here is one such patients where, immunocompromised patients, the patient was on acyclovir, and despite the treatment, you can see it just progresses relentlessly. So it is just not the antivirals alone which helps. The host immunity also has to help in the resolution of infections in the management of any infection, and acute retinal necrosis is no different than the rest.
Absolutely. And the emphasis and the understanding that the patient's compliance with the heart treatment is again a very important point while managing the immunocompromised patients, especially the infections at any point in time.
Yes.
So we have seen the bilaterality, and now I think all of us understands that, the relentless nature, how it really does not respond to antiviral, and how it kind of starts progressing towards the posterior pole. So what's your take on the chirales? Because chirales is, like, as we all know, it's an arterial involvement that we see, and we can see that right at the time of a retinitis or over a course of treatment as well, we can see the chirales. So this is one of our such patient.
Now, I think we have not dealt too much on the vasculitis part of it, right? We discussed about vitritis. We discussed about extensively about retinitis, right? Now, I think we'll just spend a little bit on the vasculitis part of it. And the chirales is again a giveaway, right? Just like pigmented keratic presperates makes you think of a possible infectious etiology. So also chirales should be you should consider that it's a possible infectious etiology. And why I think it's important, right? So I know most of you would think that, what is all about uveitis? 90% of the time I can give corticosteroids and everything gets better. So that's a general rule. But when you're dealing with a disease as that, where the remaining 10%, when they come with infection, here you have an opportunity to differentiate between an infectious and non-infectious uveitis. Now, I told you about anterior pigmented keratic presperates. In posterior segment, if one gets to observe chirales vasculitis, then you're most probably dealing with an infectious etiology. For a moment, you forget about acute retinal necrosis. Wipe away. Consider a chorioretinitis just close to the fovea, right? Imagine a chorioretinitis very close to the fovea, and you would the first question which comes to your mind, is this infectious or not? Because it's so close to the fovea. So you have to say, if it's the first differential for the etiological agent, we are not sure what it could be, but whether it's infectious or not, something which you had to be clear. And in that setting, right, if there is a chorioretinitis somewhere adjacent to the fovea and you see a carylis vasculitis adjacent to it, it will give you, you can sigh a relief saying that we are dealing with a possible infection. And in our subcontinent, most probably tuberculosis. You can validate on your clinical presentation that this sign is there to tell me that I'm possibly dealing with an infection. And the point which I think Anamika wants to make here is the carylis vasculitis would persist even after resolution of chorioretinitis or retinitis, right? But it is not an indication for prolonging the antimicrobial therapy.
Yeah,
So I just want to
absolutely.
make that very clear. Persistence of carylis vasculitis can happen, say, a month or a month and a half after resolution of the infection. But this is not an indication for a continuation of the antimicrobial therapy. I'm using the generic word antimicrobial, but in this particular case, I would use it as antiviral treatment.
Yeah. So this is also one of our patient who had a bilateral involvement of acute retinal necrosis. This is the area where we can see that here we can see a little bit of pigmentation, some kind of a retinal atrophy. So these all are the area where the patient had the retinitis, and post resolution of retinitis. Why I remember this patient is because I was about to laser this posture tear for the patient. And before looking at that, I think I just fell for the carylis, the beautiful carylis that is there. And that's when personally I learned this point that we need not continue the treatment because that's not an indication for treatment after the resolution of retinitis. So with that, let's come to the 9th question for this evening. So what really comes to your mind when your patient who you are treating comes to you and tell you that, doc, I'm not able to see very well. I was all okay yesterday. What happened?
Okay, that's something which one has to grow up with when you're managing acute retinal necrosis. And again, I would stay with the vasculitis part of it. Can you move the slide, Anamika?
Yeah.
Right. Now, let's divide an acute retinal necrosis in 2 settings, right? The acute setting, right? And then you have the cicatricial setting. So in acute setting, let's consider a time frame for the ease of involvement, 1 month. So if a patient presents with 1 month, that on treatment, you started the patient on valacyclovir, right? You started the patient on steroids and everything is going well. Suddenly this patient shows up and says that, I'm not able to see like what I used to see yesterday. So the first point which should occur to you is the presence of optic neuropathy. And why am I talking about optic neuropathy? Am I drawing some parallels with vasculitis? Yes, I'm drawing some parallels with vasculitis here. Now, here again, I would like to just detour here. So we have grown up with an understanding and passed different exams that if a patient has arthritic ischemic optic neuropathy, the one disease which comes to our mind is giant cell arthritis, right? For that, the patient has to be extremely elderly. The moment you say, everybody says you're fantastic, you made a beautiful diagnosis, you can pass the exam. But let's look at into more practicality. Arthritic ischemic optic neuropathy is one of those important things which can happen in an elderly in giant cell arthritis. But it does not mean arthritic ischemic optic neuropathy does not happen in other diseases. Now, acute retinal necrosis is one condition where predominantly artery and arterioles are going to be involved. And the ischemic optic neuropathy, which the patient can present with here, is going to be arthritic. And that's the reason why the patient can have a very steep fall in the vision. Right? So I'm trying to make people understand why optic neuropathy happens. It happens in an acute setting within the first 1 month. So, and it also tells us that the current treatment which the patient is on may not be adequate. right? There are only two types of treatment you want to play with here. You have the antivirals with you on one hand, and then you have the corticosteroids on the other hand. So let's consider in the first month, you're liberal with corticosteroids. You belong to that family where you don't mind giving good amount of corticosteroids along with antivirals. So 60, 70 milligrams, but still the patient on 60, 70 milligrams presents with pale disc and vision dropping to 1/60 or 2/60 or count fingers 1 meter. So what are you going to do with it, right? So we have to do something different. It's just 60 milligrams is not helping the patient. The antivirals is helping. That's where you have to step up your corticosteroids. You can pulse the patient if you made a diagnosis of acute retinal necrosis or viral etiology, which is correct, you pulse the patient so that it's a time to revive that optic nerve which have got inflamed because of the arthritic involvement because of virus, right? So that's one of the important differential one can expect if it's going to be a dramatic decrease in vision. Another point which I would say is on treatment, which is of practical significance for most of the vitreoretinal surgeons as well, is you start the patient on treatment, there is an intense inflammation in the eye, right? So let's say, for the sake of example, the patient had 20/80 vision or 20/60 vision to present with. In a day or two, the vision drops down to 2200, that's 660. And then the media becomes very hazy, right? Yesterday, I was able to see the peripheral retina. I saw some sort of a resolution happening, no new lesions. Suddenly, I see the media becomes extremely hazy. So what does one have to consider here, right? So the posterior hyaloid can detach, right? And we also have to understand when the posterior hyaloid detaches because of the inflammation, the posterior cortical vitreous can be studded with numerous inflammatory cells. And this posterior cortical vitreous, which is studded with numerous inflammatory cells, would give you the appearance of a very hazy media, which was not there yesterday. This should not deter you from adding more steroids. It's just the detached posterior hyaloid, but it should help you to have a very closer follow-up, because once a posterior hyaloid gets detached, so what is the next complication we are looking at? Retinal detachment. So that's why we have to be very careful about it, right? So, but this is not an indication to up the steroids, but this is an indication to inform the patient that if there is a further decrease in vision, I want to follow up very quickly because the next possible complication is around the corner. So I have to keep watching for you, right? So, and in the second month in the cicatricial phase, where the retinitis starts resolving, the vitritis starts resolving, the posterior hyaloid detaches, and then the chance of retinal detachment, which is nearly very high, starts appearing. So 60 to 70%, multiple sieve-like breaks, and it's a very difficult condition to manage. More about it when we consider or keep discussing about vitrectomy later on in the presentation.
Yeah. So
I think just to recap, first month, think about optic neuropathy and rare possibility media becomes hazy, detachment of the posterior hyaloid. And the second is about retinal detachment, usually happens in the cicatricial phase. That's in the second phase when the retinitis starts resolving. Just for ease of remembering.
yeah, the first and the second month, that was our pearl as well. So you were speaking about the arterial involvement. So have you come across the central retinal artery occlusion preceding the presentation of acute retinal necrosis? What are your thoughts on that?
Yeah, I did not get into that, the very atypical manifestations, because I'm trying to build up the fundamentals here. But because you asked me the question, yes, it can start involving from the optic nerve. See, one eye had developed acute retinal necrosis, and this virus has transgressed and affected the other eye and has presented with central retinal artery occlusion and even vein occlusion, right? So when the optic nerve has been affected, it can present with artery and vein occlusion together as well.
Yeah. Thank you for that extremely valuable point. So I think we have come to this juncture again where we'll ask our viewers about their three muddiest points over the last few minutes that we have spent in the second half of the presentation. I request everybody to please scan this QR code and write in your Maria's point, things that you have not understood.
Sir, interesting points about initial, say, diagnosis and then the management part and how to titrate the steroids as well. Sir, I would like to ask, when do you want to start the steroids? This is a common question, I guess. You must be getting post starting antivirals when? And
Absolutely.
is IV MP your preferred choice in every situation, or you would like to reserve it for a very severe vitritis or optic nerve involvement only, or as a rule you start it after starting antivirals?
Okay. So we are jumping into a very inflamed area, Ganesh, right? The whole world is divided, right? The world which treats infection is very steeply divided, and it is very hard to convince one group or the other of usage of corticosteroids. So I stopped convincing one group or the other of the influence, the wellness of the steroid, because a group of people do not believe in steroids. Some people believe that, steroid under an antimicrobial cover has a good role to play. I belong to the second group, where use of corticosteroids under the cover of antimicrobial always has a good role to play, except in certain slow growing organisms, but that's beyond the scope of discussion today. Now, you spoke about methylprednisolone. Methylprednisolone is a drug of choice for me only when I suspect an optic neuropathy happening. So otherwise, I don't do methylprednisolone in these patients. Okay. So having said that, how do I manage these patients with corticosteroids? So how can we apply or use corticosteroids in these patients? What do we have? We have topical, right? We have injectables. We have orals, and we have intravenous administrations. And I told you very clearly about the intravenous on methylprednisolone. I don't get into that aspect of methylprednisolone other than optic neuropathy. Now, in terms of topical, and the patient has an anterior inflammation, yes, you can use liberally topical steroids. And if the patient has scleritis, the pain goes away, fair enough. But you don't have to go in for a longer period of time. So, and in terms of oral, it's nearly about 60 to 80 milligrams of corticosteroids I usually use in these patients. And now the juggle, which I'm going to talk about, is the usage of intravitreal steroids, right? If the intravitreal inflammation is overwhelming, right, and I know if the retinitis for sure is responding to the antiviral treatment, it is then when I juggle and use intravitreal steroids in the form of triamcinolone. That I published the paper as well. So otherwise I don't. First, I should feel that there is a need of an extra amount of steroid. And second, I should be extremely sure that the patient's retinitis is resolving. Because once you're not sure about it, don't ever try to deal with it. The caveat is, suppose if you're not sure about the diagnosis, and in case if this acute retinal necrosis happens to be because of toxoplasmosis, we have missed it. The patient will develop infectious scleritis and then perforate, and it's no turning back, right? So that's the reason why under the cover of antimicrobial therapy, which has a clinical response. Now, the next point which you raised is immediate or after 48 hours. So I'm the type of person who would like to do immediately along with antiviral treatment. I want some sort of an steroid getting into the eye to reduce the inflammation. If not for IV intravitreal dexamethasone implant, I would still like to inject intravitreal dexamethasone, which works for about 48 hours to reduce that inflammation in few cases. But I'll come to that when we discuss about the treatment. It's just a brief to make you understand the various ways by which we can administer corticosteroids and when we can use them. But it's a personal preference also comes in play. But I don't try to convince one group with the next.
Yeah, it's a absolutely contentious issue most of the time, I guess. Dr. Deka sir has been practicing for more than 3 decades now. Satyen Deka sir, if you could unmute yourself.
Satyen was my senior. We were very good friends.
Yeah.
Hey,
Right.
Satya.
So Deka sir. So can you hear me? Okay, some connection issues. Dr. Kaushik, if you can sort that out.
Okay.
Deka sir? Yeah.
Yes. Can you see me now?
Yeah. I can.
Yeah.
We can hear you, sir.
I
Okay.
think Satya is in
Actually,
Kaziranga, I think.
yeah, no. Actually, there are some storm is coming, so I'm just now. You can see me.
Yeah,
Yeah.
you're
So I,
come.
Avinash, yeah. So
Yes, Satya.
what? Till now, what I have listened, the way of discussing acute retinal necrosis. This is a wonderful way that because this acute retinal necrosis itself is a not very common thing, not a common disease that everybody has seen in day-to-day practice. When you be in a tertiary care center, then only you have the luck to see this kind of cases, and I'm very happy that Avinash has so nicely presented, so nicely answered all these meticulously. He has answered these points, and I think once people think that acute retinal necrosis is a condition, not for me, it's for the higher center. Now I think all this 88 or somewhere around more than 80 people are looking at this presentation. They have a crystal clear idea about the acute retinal necrosis. And of course, the clinical experience, if you say, few cases we dealt, but since the period we started our fellowship days until now, so many changes in this practice pattern itself. Because when you see a case of acute retinal necrosis with retinal detachment, we saw our senior surgeons doing retinal detachment surgery. It's a something difficult surgery. But if we can diagnose at the early stage, before it attack the optic nerve or the retinal detachment happens, the proper treatment, it works. And Dr. Avinash, I think he will come to the next part that how to treat this. Till now, whatever the treatment, whatever the discussion is going on, and I think people are very clear about this clinical pathology part and differential diagnosis. All these minor points, Dr. Avinash has very nicely he has explained. So thank you,
Thank you, Satya.
Avinash, and I'm very happy that so many people are very eagerly wanting to learn this, not very common disease. And Avinash is the perfect person to train all of you, all of us. Thank you, Avinash. Thank you so much.
Thanks, Dada.
Absolutely. Sir, one more thing that I'd like to ask, as we were discussing about, say, a thrombotic phenomenon in such patients happening, does aspirin has any role in such situation?
So aspirin came in. There are a lot of things which comes in the treatment, especially, and now it is of medieval interest.
Right, sir.
Yeah.
Sir, anything that you do to say if you see a necrotic and a non-necrotic part to laser before there is a detachment happening, a prophylactic laser in the attached retina non-necrotic area?
It is coming up, Ganesh.
Yeah. Okay, sir. Okay. And Dr. Ananimika, any questions that you could take it
Ganesh is
out?
prophesizing what is coming up next, actually. Intuitively is way advanced.
Yeah, so actually we just have two questions. The first question is that could a PST injection can be given to the patients of acute retinal necrosis?
So this is just, I'm not going to say that it cannot be given, but when someone injects a deposteroid, right, this is just a general information which I pass on to every person who deals with infection or in uveitis. Make sure you're dealing with something which you are completely aware of. And number two is it is responding to the antimicrobial treatment. And number three, it has to be under the antimicrobial cover. Now, if it's going to be intravitreal, the treatment has to extend for 3 to 4 months. because that's the amount of immunosuppression, local immunosuppression it is going to cause inside the eye. If it's going to be periocular subtenons, it is nearly about 4 to 6 weeks, right? So this is what something which these 3 points you remember very well before you make sure exactly what you're dealing with. If you're not sure, anywhere in your mind, if you think you're not sure what you're dealing with, do not do depot steroids. Second, it has to be under the cover of antimicrobial till the duration of the steroid exists. And third, you have to see a clinical response.
Yeah.
Tick these 3 boxes.
The second question we have is, how would you differentiate between the early PORN from the acute retinal necrosis?
So PRN is very rare to see now. It's as the name suggests, it mainly involves the posterior pole. Now, what is fascinating about this is it's the same group of virus, right? It's the same herpetic group of virus, but in one setting the periphery is involved, whereas in another setting the posterior pole is involved. So the curiosity one should have is why the same virus manifests in 2 different forms. Right, that's some very simple curiosity. So there are no perfect answers for this. So when there is no perfect one answer, we give different reasons. One, the different reasons being, one, the viral load must be very high. Number 2, the host immunity is very less. Okay, and the third, the host immunity, either local or because of systemic implications, can be affected, so that even with the little amount of virus which the patient presents with has manifestation right at the posterior pole of the disease. So these are the various hypotheses one can play with to make people understand why a similar or same virus can manifest 2 different points. We know that PORN usually happens in immunosuppressed patients, and it is a very unforgiving disease, extremely unforgiving, because it's 24 to 48 hours. It can turn a patient into no perception of light, absolutely no perception of light. So if you think that you have, this has been the first time I got to see a patient with PORN, I was in doubt whether this is PORN or not. So what I did was I called the patient next day with one of my colleagues, and the next day the patient was from 2030, the patient was no light perception, as aggressive as it can get. So those are points which just my own bad experiences. I think you guys should not make that mistake.
All right. So let's move on to the third part of this presentation, where much awaited, I think, about the treatment part. So what's the choice, valacivir or acyclovir?
So the evolutionary learning in the initial part of her life, it was acyclovir, admit the patient for 2 to 3 weeks and inject acyclovir for these patients. That's been how our initial practice was till acyclovir came in. So like in the management of cytomegalovirus, we also have an induction phase here, right? So induction phase where for 2 to 3 weeks you give 12 to 13 milligrams kg body weight of acyclovir to inject these patients, admit the patients. But with acyclovir, acyclovir coming in, the bioavailability increased, so these patients need not be admitted. So I don't admit these patients anymore for intravenous acyclovir. But the question is, has the dosage matched? Right? The conventional thought process is 1 gram 3 times a day of valacyclovir is good enough, or 2 grams of acyclovir, valacyclovir is equivalent of intravenous dosage. The answer is 2 grams of 3 times a day of valacyclovir is good as intravenous acyclovir. Okay, so if you want to have a direct equivalent of an intravenous acyclovir, 2 grams of oral valacyclovir is good enough. It prevents hospitalization, the cost to the patient is reduced, and all those other people who want to talk about health economics can keep talking about it.
Yeah. So let's move on to the medical management of protocol. So first, so the first half will speak on the oral treatment, and the second would be the local treatment. So you were speaking about the 1 gram TID and 2 gram TID. So what's your choice for 1 gram and for 2 gram in acute retinal necrosis?
So when usually it's less than a quadrant is involved, I prefer to start with 1 gram 3 times a day. If it's more than a quadrant, then I go straight with 2 grams 3 times a day.
Yeah. I think this is the image, Dr. Avinash, which I think you had made that point.
Oh, yeah.
HSV2. Yeah.
I think someone, Ganesh, did you ask about HSV2? So this is one patient where you can see a retinitis, and then you have peripheral hyperpigmentation, and then you can see this retinitis here. You can also see a small central clearing there, right? Yeah, this is where we made an etiological diagnosis of possible HSV2 in these patients.
Right, sir.
Yeah. So I think everybody's pretty clear on how would the HSV2 scarring would look like, and how the 1 quadrant and 2 quadrants involvement is. So based on the immune status of the patient, please enlighten the viewers today, Dr. Avinash, about your treatment protocol.
So for immunocompetent patients and immunocompetent, let's divide them, because now there is no difference when you're managing with antivirals, right? So irrespective of whether they're competent or compromised, it's going to be one and the same. So the issue happens when you're dealing with corticosteroids. So if immunocompromised patients, it's no to steroids. So it is going to be only in immunocompetent patients. So I did mention about the various ways by which corticosteroids could be administered some time back. So you want me to repeat it, or I was pretty clear in that aspect, right?
No, we can just have a protocol.
Yeah, but I would also like to add, one more antiviral in the form of intravitreal ganciclovir. You have 2 intravitreal antivirals which could be used, ganciclovir or foscarnet, right? But foscarnet is not easily available here. It has to be imported. Then ganciclovir can be tried. I prefer to do ganciclovir when there is more than 1 quadrant involved.
Yeah.
Right. And continue the antiviral treatment for a minimum of 2 months. Minimum of 2 months. Because one of those goals of the treatment is to prevent the other eye being affected. Right. So, but when it happens in immunocompromised patients, so immunocompromised patients, how long the antiviral has to be continued? That's important. So let me start by saying it's not an AIDS-defining disease. Unlike cytomegalovirus, this is not an AIDS-defining disease. So one does not have to consider that though the patient may be HIV, that he has gone into AIDS. Second is we have to continue this treatment till the CD4 cell goes on up to 200 in these patients. Not as in terms of very typical. You don't borrow all those from the management of cytomegalovirus, but the CD4 count has to go beyond 200, and then you stop the valacyclovir in these patients.
Yeah, and I think the point of after the resolution of retinitis, we have to continue the treatment for 2 months, which is TID. Again, it's extremely important for the understanding while managing these patients. So this is one of my favorite tables where it just makes a point about the cost and the predictive efficacy. Would you like to say something on this? Because it has got all the antivirals here.
Yeah, but I will refrain from the cost and the health economics point of view.
Yeah.
Because but I would like to talk from the pure in terms of what a clinician should gather from the slide, right? So we have, let's consider 4 types of viruses which we have to deal with. So HSV2, HSV1 and VZV, and very rarely cytomegalovirus, which can present like this as well. Very, very rare. So you leave that in the bargain. You don't forget the remaining 3, HSV2, 1 and VZV. So how are we clear in understanding these antivirals in terms of their effectivity towards these 3 viruses? This slide is extremely important for us. And you will see acyclovir and valacyclovir, because both one and the same, are towards HSV2 and HSV1, they are one and the same, right? towards HSV2 and 1, they are better than VZB. Okay, this is something which is easy. If it's going to be famciclovir is again 500 milligram 3 times a day, ease of administration. It is little bit better than for HSV1 compared to HSV2 or VZB. And what stands out here, VZB, if God has to ask you which one you would like to choose, don't choose. Which one you would not like to choose, don't choose VZB in ARN. Right? Do not choose VZB because its antiviral capability of the existing drugs is not extremely good. Okay, so HSV1, HSV2 is still a better bargain you can have with God at that point of time, or Yamraj if you want to have. It's not a nice disease to have it. But remember, VZB is not something, it's very kind in terms of the antiviral treatment. Now let's move on from acyclovir and famciclovir to ganciclovir. Now, we do understand that ganciclovir, the moment someone talks about ganciclovir, immediately we go towards cytomegalovirus. Very good about it. There's nothing wrong in it. But we also have to understand ganciclovir also has a good activity against HSV1 and some sort of a decent activity against HSV2. VZV anyway, everything, usually it's lost, right? So if, to draw a very simple analogy, if you want to remember this, if someone has to run 100 meters dash and someone has to be, crowned for the first place, it is always, you look at HSV2 as the first place, HSV1 as the second place, and VZV as the third place, right? Because you always score better. So that's how it is for ease of understanding. And also understand that ganciclovir, though it is very good for CMV, it is also good for HSV1 as well. And when it comes to foscarnet, it's good for HSV1, 2, and VZV and CMV as well. But unfortunately, we don't get it.
Yeah. So thank you for that. And so what about your preferred drug of choice for the intravitreal drugs?
So preferred drug of choice because of the availability of ganciclovir. I do inject ganciclovir in these patients. It's 2.5 milligram, very easy.
Yeah.
You take the 500 milligram vial, just withdraw 0.05 ml and jab into the eye. Okay, so that is for more than 2 quadrant involvement. And when to repeat? You repeat once after 72 hours. If it's foscarnet, which I have never done it so far, it's 2.4 milligram. And it has a longer duration of action. We have to inject once a week.
And what's your take on the MIC of these drugs, if he has to compare between the GAN and the foscarnet?
So the minimum inhibitory concentration of herpes virus in rabbit eyes is 60 hours for ganciclovir and 36 hours with the intravitreal foscarnet respectively, right? What is being mentioned. And that is the reason why we usually go for twice weekly injection of ganciclovir. If we directly extrapolate the information, what is available in the literature in animal experience into the human eyes. Now, what is the point which we have to discuss here is when we administer intravitreal ganciclovir is anything over 2.5 milligram has a potential towards toxicity, right? And sometimes it becomes irreversible as well. So that's why you have to have, because there are some studies which goes in even for 5 milligram of ganciclovir. Yeah, it is good in certain aspects, but not at the expense of irreversible toxicity in certain patients. So I'm pretty safe and there is no dilution there. There's no component dilutional error. Just pick up the 500 milligram vial, withdraw 0.05 ml and jab into the vitreous.
Yeah, pretty straightforward. You're making it very easy for all the ears that are listening. So now we have taught how to treat. So how do we know that the treatment is working?
Yeah, so this is something which we have to know because till now we had the challenges in terms of diagnosis. So what regimen one should adopt and how we should treat and interplay between the antivirals and the corticosteroids. So having done that, so how do you going to see the response of the treatment? So the immediate response and immediate after 1 week. Immediate responses, there should not be any new lesion happening within 72 hours of starting the treatment. That's extremely important. So don't look at rounding of the borders, central clearing, the disappearing of the retinitis within 72 hours. It does not happen. It takes some time. So it takes nearly a week to see that the whiteness starts becoming gray, the margins becoming sharper, and then the atrophy starts happening from the margins. So that's what you have to be very clear when you're re-examining the patient after a week.
Yeah. So I think the point that you just raised, that we need to look at the borders probably after a week, is extremely important. And within 72 hours, we should not see a new retinitis sprouting up. And as we can see here, the retinitis, which was very white, it has started becoming duller. The borders have become so sharp, and later on it just goes away and you see the atrophy. So the point which you had already raised, that the viral retinitis predominantly, they do not heal with the pigmentation, barring HSV2. So with this, I think Ganesh is going to like this question. The role of laser versus VR surgery in ARM.
Right. This is a very old slide which I just used it. Till the paper which was published by Carlos Pavesio. Right. So before that, the patients used to be sent to photocoagulate the posterior margins of retinitis. So what we found was that it's very hard to photocoagulate in the presence of dense vitritis in some of these patients, right? And invariably, the patient presents with very severe retinitis, with the dense vitritis. When you're not able to photocoagulate completely, these patients develop retinal detachment. They already have a possibility to develop multiple sieve-like breaks. And if the laser marks are fresh, right, they are going to create 1 zillion holes there to manage, right? So that's from the practical limitations because of the vitritis. And if the retinitis progresses, then it becomes extremely tough. So the manuscript very clearly says the role of prophylactic laser to prevent is debatable, just because of these two problems what I just mentioned, because of the inherence of vitritis and not allowing a complete laser photocoagulation possible. And in terms of progression, then it can rip numerous holes and cause an instantaneous detachment in these patients.
Yeah.
Now I would stay with this. I'll give you some sort of an historical perspective as well. So earlier when we were doing fellowships, and one of those classical teachings which was promoted by the Mass and Ear Infirmary, Donald D. Amico, was to perform prophylactic vitrectomy in these patients, right? But somehow it has not stood the test of time, and it has disappeared as a recommendation in terms of management. So prophylactic vitrectomy, once a vitrectomy is being thought of in these patients, there are many more difficulties. One, I told you, PVD is already induced. It's so easy to do the core vitrectomy. It is not difficult to do the core vitrectomy. So the challenge is not doing the core, but the challenge comes when the interface between the necrosed retina and the attached vitreous to the necrosed retina happens. So it is extremely hard. You will not know whether you're cutting the peripheral retina or the peripheral vitreous, because there is significant amount of vasculitis and occlusive vasculitis. The arterioles have been involved, and the retina would also not bleed. You will not know that whether you're cutting the retina or you're cutting the peripheral vitreous, right? So again, the conventional teaching, because start cutting the retina, it'll start bleeding. But here it'll be extremely difficult unless you come at the margins. So how you manage the situations where, when you're cutting the peripheral retina and you're not sure. So I usually take the help of triamcinolone, diluted triamcinolone inside the eye, and see that if these particles get enmeshed in between the fibrils which are there, and then I slowly start trimming these areas. And needless to say, I support them with the buckle so that some part of the retina which is I'm not able to cut would be supported by the buckle. Now, there are certain cases where I know I have to do a 360-degree retinectomy. Then I don't support it with the buckle. And then I have to cut the peripheral vitreous and the peripheral retina. I do it at the first go itself. I don't wait for it to recur, right? I have to make that strong decision before operating and make a 360-degree retinectomy with perfluorocarbon retained inside the eye. And then the retina reattaches and replace the perfluorocarbon with oil at the end of 1 to 2 weeks, right? That's something which I prefer to do in these type of cases. Now, why the challenges I said about inability to differentiate between the posterior cortical vitreous and the retina because of its attachment, and also the avascularity because of the vasculitis which is there. One more inherent problem which we can see is anterior PVR. We know anterior PVR usually happens in following the vitreous surgery, right? When the patient comes with PVR, anterior PVR is something which happens then. But this is one of those rare conditions where anterior PVR can be present in a primary setting. So do not forget to address the anterior PVR. Okay. Now, having said that, why am I talking about anterior PVR and addressing anterior PVR? Because we also have to understand that though you settle the retina, there's a significant amount of complications which can happen post-operatively, which goes beyond our control, and that's hypotony. Now, I want to discuss a little bit more about hypotony because it is from here these patients are going to stay back with the vitreoretinal surgeon. They're not going back to the uveitis specialist, right? So when the retinitis happens, in the peripheral retinitis, it has a tendency, as and when you see a tendency to progress posteriorly, one should also consider it can progress more peripherally to the ciliary body as well. Okay, so the progression happens anteriorly and posteriorly also. Because we are able to see the posterior with indirect, then we look at more of posterior progression, which can happen later in the course of disease. But we completely are oblivious to the fact that the peripheral extension, anterior extension can happen. And it is here the virus can destroy the ciliary processes, or the anterior PVR can exert attraction on the ciliary process to cause hypotony. The hypotony can be caused due to two reasons, either because of traction of the anterior PVR or the virus destruction of the ciliary process, or theoretically, to be correct or to complete, it can be both. Both the mechanisms can be involved here. And that is one of those reasons why there is a very high chance of hypotony in these patients after the surgery. And some of this hypotony is irreversible many times, so one has to retain the oil for a longer period of time, right? So consider, we know that when you have retained for a longer period of time, we consider injecting a 5,000 centistroke oil inside the eye and leave it inside the eye for a good period of time. Now, if the patient is faking, the patient has hypotony, right, and has a 5,000 centistroke oil, and slowly the patient is developing cataract. So what do we have to do after that? So my practice is, I prefer the anterior segment. I don't do cataract. I have limitations of doing a good cataract myself. So I would suggest the cataract surgeon to correct the IOL for the oil inside the eye. The IOL power to be corrected for oil inside the eye, so that the patient will be close to emmetropia, not perfect emmetropia, but certainly better than having a +5 glass to be utilized for his optical corrections. So that's something which I would like to suggest. If someone wants to use it, can certainly use this tip post-operatively. And the second tip which I would also suggest is, since the patient has hypotony and an oil inside the eye and prolonged amount of uveitis, this is one condition I prefer to use difluprednate 3 times, 4 times, just to sustain the intraocular pressure inside the eye. And I would also give a practical tip, if for all those patients which have used for difluprednate for a longer period of time. For some reasons, I have not seen very early emulsification happening in these patients. The pressure is sustained, the inflammation is controlled, the eye is quiet and white, and the early emuls or the late emulsifications we can prolong as many days as possible. So those are 3 additional points which I would like to suggest if someone wants to manage post-operative hypotony in patients with acute retinal necrosis.
Yeah. I think beautifully elaborated on each and every aspect, probably which I thought of asking also. You have already answered those. So, Dr. Anamika.
Yeah, I think we have come to the end, and I'm going to ask the 3 muddiest points again, if at all we have from our viewers.
Yeah. So meanwhile, people type in, I think we can take points from Dr. Tatiana. Your comments, Doctor.
Thank you so much. It was so educative. I also have a patient. He came to our clinic with one blind eye, was bilateral necrosis, and second eye was with exudate in anterior chamber vitreitis, retinal detachment. I did vitrectomy, silicone oil, tried to clean everything, and it seemed that his eye was good, and I decided to remove silicone oil in 6 or 8 months. After that, he had very aggressive PVR. I had to make 360-degree retinotomy, and since that day he with silicone oil tamponade. His visual acuity 0.05 and 0.1, so 5 or 10% from time to time, and he got every day he got topical diluted solution of dexamethasone. I'm happy of this result. He was heroin addict before, so it's very this pathology is also like a destiny of the patient and his family. So it's very interesting how to see it in general, how to understand this process when we can do something before. Thank you. Thank you so much.
Those are very important points what you mentioned, and it's a very frustrating disease. Why I felt as a vitreoretinal surgeon, I'll tell you, I was not, I must confess, I'm not a trained uveitis guy. I felt it was important for me to understand more about acute retinal necrosis for the reason that once the retina detaches, the ball is in our court, right? So I was just feeling that how to manage these patients, maybe in a way, the uveitis guys usually follow the same aspect. It's like 60 milligram steroid, valaciclovir, then topical steroid. There's no variation. There's no tailor-made approach for these patients. And ultimately, when the retina detaches, when they send these patients, we have to manage these patients and then continue with the care, because headache is on us after that, right?
Yes.
And it is not going to be a good story. This story does not have a happy ending many a times.
Yeah.
So that helped me understanding more about the disease, and understanding in such a way that it made me also manage these patients in the way I would prefer, so that the incidence of retinal detachment can decrease and we don't have to take them for vitrectomy. As much as possible, if we can avoid vitrectomy in these patients by good medical management, we have made the patient very happy there.
Thanks. Yeah.
Right. Dr. George?
He left
Rocha.
the panel. He had to go.
Dr. Deka, sir?
Dr. George is gone.
Yeah, Dr. Deka, sir?
Yes. Hello, can you see me?
Yeah. Deka, sir,
Can
your
you see me?
points. Yeah. Not yet, but yes, now, sir.
Yeah. See, what we have learned from this part of this ARN discussion, the retina get detached. Then I think most of the vitreoretinal surgeons fine, okay, let's go ahead with the vitreoretinal surgery, put silicone oil. But Dr. Avinash has clearly mentioned these vitrectomy cases are not that easy. Also, you'll see once you start doing the vitrectomy in the periphery near the necrotic areas, you start creating breaks, multiple very the suction. So the surgeon, once they go near the this retinal part, the retinal break starts happening. Though initially it was 1 or 2 breaks you could see, once you start doing the surgery, the retinal breaks number will be more. So, and of course, it does not matter whether the number of retinal breaks more or less, because already you are inside the vitreous cavity and your basic idea to remove as much of vitreous has to remove, and because you are going to put the silicone oil. And what also I suggest, if we are not going up to that point where we have to do 360-degree retinotomy, better to put the belt buckle in a broad way. I have seen some surgeons, they use a 270 buckle instead of 240 what we use. It gives a breadth, give a better broad areas. So a broad buckle effect with your vitrectomy and 5,000 centiscope silicone oil.
So I think there is some connectivity issue. Yeah.
Now, can you hear? Hello?
Yes, a little clear. Yeah, better.
So yes. So a broad buckle effect, if we can do along with the vitrectomy, I think that will be give a better result. Let me tell another interesting point. A young boy who developed this RD retinal detachment and say extensive surgery we have to do. This boy developed anterior segment neovascularization and in a silicone field eye. We cannot remove the silicone oil also because we know that again retina is going to detach. So at that time, I think anti-VEGF already has come. So I tried to give half dose of intravitreal in the silicone oil, inside the silicone oil. And I could see, yes, very soon the anterior segment neovascularization got regressed. So I had to repeat this time to time in the initial phases. And this, I think Dr. Avinash can remember this case I discussed in some of our BSA meetings. I told, what next? How long will give the anti-VEGF? But the very recently that boy came, now he is a young person. Everything is quiet. I don't know how it happened. At this moment, everything is quiet and retina is also. So I think Dr. Avinash also can highlight if anything, something like this segment neoevolution in this kind of cases. What a message can be given to our
Yes, Satyen, because I think I did not touch this point about a very rare complication of anterior segment neovascularization. So as much as we can consider for anterior segment neovascularization, even posterior segment neovascularizations can happen in these patients. It's a very difficult one to manage. Now, when you look at anterior segment neovascularization, is it a matter of concern just because anterior segment neovascularization happened? Or it's a matter of concern because anterior segment neovascularization has happened for it to be associated with raised intraocular pressure, right? So Satyen's case, we are looking at possibility of raised intraocular pressure, then it's a matter of concern. But if there is a pre-existing hypotony and there is one twig of new vessels which is growing in 1 clock hour or 2 clock hour, which seems to be sort of resolving with anti-VEGF injected into the oil, but later on it recurs and just continues to stay there and not cause any raised intraocular pressure or hyphema, you leave it alone. Then over a period of time with steroids, it starts resolving. You don't have to keep on injecting every month anti-VEGFs in these patients, and unless and until it is showing complications in terms of hyphema or raised intraocular pressure.
Yes. So our concern is glaucoma, but if already hypertony is there, I think Dr. Avinash is correct that we should not be very much concerned about this situation.
Right, sir. So there are a few questions in the chat box. In an immunocompromised patient with vitritis and ARN, how to start treatment? Means is
In
vitritis, yeah.
Immunocompromised patients with acute retinal necrosis, right? You start with antivirals, it will be the predominant form of treatment. And yeah, the question is not about antivirals, right? It is pretty straightforward. The challenge is whether it is responding to antivirals or not. If it is not responding to valaciclovir, I would suggest the possibility to shift to famciclovir and continue with ganciclovir. And if it is not responding to both, then unless and until you have hands on foscarnet, otherwise it's like RIP. You can't do anything more about it, right? So that's the best what we can do.
Sir, a personal question. After seeing a 2-quadrant involvement, do you straight away go for intravitreal injection of antiviral?
Yeah, it's an adjuvant therapy.
Yeah.
Yeah, it's an. I usually go with two antivirals, one inside the eye, and one in the form of systemic.
But you do it for every patient where there is more involvement?
Yeah, it's a personal protocol. I have not published that, but it's a personal protocol.
Right, right. Dr. Atul, your thoughts on the beautiful presentation and the way it has been covered. A topic which may be very dull to take if it has to be really in a lecture form, but because it was a discussion form, we could relate to each and every point, I guess. Dr. Atul?
Avinash sir has promised me he'll make the lecture so beautiful, so interesting. I told, okay, sir, whatsoever way you want to do, you can do. Because I have already attended his so many lectures during the conferences. And he is presenting in the same way. Because you remember for a very long time, his all the points. And from our side, I'm requesting, sir, please give us this chance to host the lecture on endophthalmitis also, sir.
I'll do that.
Avinash, sir.
I'll do that. And another, because I promised you already, Atul, I'll do that. Sometime later, I'll certainly do that.
Yeah,
Absolutely.
whenever you are free, sir. One lecture on endophthalmitis I want from you, sir.
Yeah, I'll do that.
It's a beautiful way of covering, and one of the muddiest point which was mentioned here is how to make such beautiful presentations.
That was my concern. I was concerned like it's the muddiest point. So
excellent lecture, sir. Excellent. And it's for everyone, not only for the uvea person, but also for the VR side, because we are getting the case at the end. So if you get the case in the early phase, how to deal the case if no uvea person is available in our clinic?
They will not be available. You will have to inherit a bad property, right? You will have to have the headache of inheriting a bad property. That's the reason why they will not even show. They will not show up. That's it.
Right, sir. So,
thank you very much, sir.
Yeah,
Ganesh,
closing
sir?
comments from Deka sir and Dr. Tatiana. Dr. Deka sir, closing comments.
I think some connection lost.
Yeah, Dr. Tatiana,
No.
your closing comments.
Yeah.
Thank
Now
you
hear
so
me?
much, Dr. Atul, for your invitation and dear colleagues to be with you today. Thank you so much. It was very fruitful. And I made a photo of dosage of the treatment. So I need to have this treatment in the table and will share with my colleague as well. Thank you so much. Because I'm as a vitreoretinal surgeon, I have only last stages with detachment stories. So it's very interesting to be with medical retina colleagues to treat together. Thank you so much.
I think
Deka, sir?
this lecture, yes. So this lecture will prompt all the doctors not to go towards the surgical part so that we can prevent developing retinal detachment. And Dr. Avinash just very nicely, he has brought all the points that let's not go to that extent we have to that. And yes, definitely it's very nice presentation. And the acute retinal necrosis itself, as you, Dr. Ganesh told, this is not a very palatable, palatable disease that to discuss. But I know the cook is something extraordinary, Dr. Avinash. So nicely he has cooked this particular disease. Now everybody can remember for a long time. So thank you, Avinash, again. And
Thanks,
I congratulate the whole team also.
See you.
Yeah. Thank you,
Thank you.
Avinash sir and Dr. Anamika, for a wonderful presentation and opening our minds to a new way of dealing with difficult diseases. So from our team of ASG, which includes Dr. Kaushik Tripathi, Dr. Atul and Dr. Mayank, I, Dr. Ganesh Pillai, would like to thank everyone who have joined us. More than 90 people joined us for this lecture, and it's very heartening to see so many people joining in for uveitic talk, more of a presentation which will be remembered for a very long time. Dr. Avinash sir, thank you so much.
Thank you again
Thank
for
you
the
so
invitation.
much.
Right.
Thank
Bye,
you, sir.
guys.
Thank you.
Thank you,
Bye,
everybody.
Atul. Right.
Thank you,
Bye.
everyone.
Bye bye.
Good night.
Thanks a lot.